My name is Dr. Madison, and today I am reviewing the 2024 hypertension guidelines, so please pay attention. There are three types of arteries: elastic type aorta, large arteries. The wall of such an artery contains mainly elastic fibers. Muscle elements are practically absent. Secu, transitional type arteries of medium diameter. The wall contains both elastic fibers and muscle elements. Third, muscular type arterioles, precapillaries. The wall contains mainly muscle elements. It is the aorta, as the largest elastic artery, which also directly connects to the left ventricle, that serves as the main buffer of the pulse wave. The main reason for the loss of vascular elasticity with age is the degradation of elastin, one of the strongest proteins in our body. Elastin provides elasticity of blood vessels, that is, the ability to restore their original shape after deformation. Elastin practically ceases to be renewed from early childhood, and what is not renewed inevitably accumulates damage and loses its properties. According to some estimates, it is the loss of vascular elasticity that determines the upper limit of human life expectancy, 120 years. What causes the destruction of elastin? First of all, we are talking about mechanical destruction. The heart beats on average 100,000 times a day, 35 million times a year, and makes more than 2 billion contractions during its life. Destroyed elastin is replaced by another protein, collagen. Collagen is less elastic. Moreover, over time, it becomes even more rigid due to glycation and cross-linking. Thus, the transformation of elastic vessels into rigid tubes ends with their calcification. In the 2024 guidelines, normal blood pressure is defined as 120/70, and hypertension is still defined as an office systolic blood pressure greater than 140 millimeters. However, a new category of blood pressure has been introduced: elevated blood pressure. Elevated blood pressure is defined as an office systolic blood pressure between 120 and 140 millimeters, or diastolic pressure from 70 to 90 millimeters. The pathophysiology of hypertension involves complex interactions between environmental and behavioral factors, genes, hormonal networks, and multiple organ systems, the renal, cardiovascular, and central nervous systems. In addition, vascular and immune mechanisms are involved. Long-term hypertension causes damage to organs: heart, eyes, and blood vessels in organs with low resistance, such as the brain or kidneys, which undergo structural and functional changes. Although these changes can be influenced by other factors, dyslipidemia, hyperglycemia. What is orthostatic hypotension? Postural or orthostatic hypotension is common, occurring in approximately 10% of all adults with hypertension and up to 50% of older adults in healthcare settings. Orthostatic hypotension is defined as a drop in blood pressure of 20 to 10 millimeters 1 and/or 3 minutes after standing after 5 minutes of sitting or lying down. Diagnosis is done in the office. Primary hyperaldosteronism. Although spontaneous or diuresis-induced hypokalemia strongly suggests primary aldosteronism, most patients with this disorder have no history of hypokalemia. Thus, the aldosterone-renin ratio is recommended for initial screening for aldosteronism. To reliably assess renin and aldosterone status, and hence the aldosterone-renin ratio, greater than 30 for hyperaldosteronism, and facilitate a clean screen for aldosteronism, a second approach is to discontinue medications that affect these variables whenever possible, before testing the aldosterone-renin ratio. Such inhibitory drugs include beta blockers, centrally acting agents, e.g. clonidine and alpha-methyl-dopa, renin-angiotensin system blockers, and diuretics. A long-acting calcium channel blockers, as well as alpha receptor antagonists, do not affect the aldosterone-renin ratio and can be used instead of interfering drugs before testing the aldosterone-renin ratio. If drugs that do not inhibit the aldosterone-renin ratio are contraindicated or insufficient to control blood pressure, centrally acting sympatholytic drugs, moxonidine, can also be used, but with a slightly higher risk of false positive results due to renin inhibition. In addition, when mineralocorticoid receptor antagonists cannot be discontinued for safety reasons, e.g., in severe hypokalemia or severe hypertension in patients with severe hyperaldosteronism. Recent data suggests that the accuracy of the aldosterone-renin ratio test is only marginally affected by such treatment, particularly in the presence of significant primary aldosteronism, pressure. Secondary causes include pheochromocytoma paraganglioma, is a rare catecholamine-secreting adrenal tumor that occurs in up to 0.2% of patients with hypertension. A small percentage, up to 10% of catecholamine-secreting tumors are extra-adrenal and arise from sympathetic rather than non-sympathetic nerves. Biochemical testing, first line, plasma metanephrines, highest sensitivity, 96%, specificity, 85%, metanephrines and catecholamines in 24-hour urine, sensitivity 87%, and specificity 99%. Elevated levels confirm catecholamine excess. Imaging, after biochemical confirmation, CT MRI abdomen, pelvis, localizes adrenal tumors. Meta-iodobenzyl guanidine scintigraphy for extra-adrenal metastatic disease. PET CT for malignant metastatic cases, genetic testing. Detection of a single tumor requires surgical removal after adequate pharmacologic preparation, since PPGL secretion can cause fatal events without warning. Adrenergic crises cause hypertensive crises and should be treated with an intravenous alpha-1 blocker, such as phentolamine, doxazosin, or terazosin, or labetalol. Labetalol also has alpha-blocking properties and has the advantage of allowing titration of the infusion based on blood pressure response and of avoiding tachycardia with beta blockade. Initiate beta blockers only after adequate alpha blockade has been achieved, usually after 2 days. If beta blockade is initiated prematurely, unopposed alpha stimulation may precipitate a hypertensive crisis. Other forms of secondary hypertension: obstructive sleep apnea syndrome, hypertension induced by anti-cancer drugs, genetic causes of hypertension, licorice excess, Cushing's syndrome, thyroid disease, hyperparathyroidism, coarctation of the aorta, and acromegaly are rare. Patients should be referred to specialized centers for treatment. Renovascular hypertension is a condition in which occlusion or stenosis of a renal artery reduces renal perfusion pressure to a level that activates the renin-angiotensin-aldosterone system, thereby increasing blood pressure. The main causes are atherosclerosis and fibromuscular dysplasia. Atherosclerosis is the most common form of renovascular hypertension, especially in the elderly. Fibromuscular dysplasia is a systemic, non-atherosclerotic vascular disease affecting the medium-sized muscular arteries. When fibromuscular dysplasia affects the renal arteries, renovascular hypertension can occur, especially in children and young women. Although not a very sensitive parameter, very high renin levels raise suspicion for renovascular hypertension is diagnosed based on imaging studies such as Doppler ultrasound of the renal arteries with bilateral renal artery, resistance index assessment or abdominal CT angiography or magnetic resonance imaging according to current ESC guidelines. Since fibromuscular dysplasia is a systemic disease, head-to-pelvic CT or MRI angiography is recommended. How does potassium affect blood pressure? Optimal dietary potassium intake, such as by eating plenty of fruits and vegetables, has been shown to lower blood pressure and may be associated with a lower risk of cardiovascular disease. The association between potassium intake, systolic blood pressure, and cardiovascular disease may be gender-specific and stronger in women. The World Health Organization recommends a dietary intake of 3.5 grams of potassium per day, 90 metamol per day. However, excessive potassium intake should be avoided, and guidelines for the treatment of chronic kidney disease recommend limiting dietary potassium intake to 2.5 grams per day in people with chronic kidney disease. A low urinary sodium to potassium ratio is associated with a greater reduction in systolic and diastolic blood pressure than a higher ratio. Patients with hypertension and high sodium intake should consider increasing their dietary potassium intake. Drug classes with proven clinical results in the target population. The main drug classes with convincing evidence for reducing the incidence of blood pressure-related cardiovascular events are angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, dihydropyridine CCBs, diuretics, thiazides and thiazide-like diuretics such as hydrochlorothiazide, chlorthalidone and indapamide, and beta blockers. The first 4 drugs are recommended as first-line options for initiating hypertension treatment in the general population. Beta blockers may be added preferentially in cases of angina or heart failure, after myocardial infarction, or for heart rate control, where they are the cornerstone of therapy. In these settings, second-generation cardioselective and especially third-generation vasodilator beta blockers are preferred. However, beta blockers are less effective than ACE inhibitors, ARBs, CCBs, or diuretics in preventing stroke and have a higher discontinuation rate due to side effects. Beta blockers and diuretics, especially in combination, are associated with an increased risk of incident diabetes in susceptible patients. Beta blockers should also be avoided in patients with isolated systolic hypertension or, more generally, arterial stiffness, as they increase stroke volume, given the low heart rate. If therapy and compliance with the above classes of drugs are optimized but are insufficient to achieve blood pressure targets, other classes of drugs may be used to treat hypertension. Of these, spironolactone, a mineralocorticoid aldosterone receptor inhibitor, appears to be the most effective in further lowering blood pressure in resistant hypertension. Clinical trial data on other classes of antihypertensive drugs, such as alpha blockers, hydralazine, and centrally acting agents, moxonidine, suggest that due to their less cardioprotective effect and more side effects than the major classes of antihypertensive drugs, caution should be exercised in their use. However, they may be a last resort when all other therapeutic efforts are insufficient to lower blood pressure. Several other classes of drugs have emerged for the treatment of heart failure that also have blood pressure-lowering properties. For example, the angiotensin receptor neprilysin inhibitor, ARNI, sacubitril valsartan, originally developed for the treatment of hypertension, reduces cardiovascular mortality and morbidity in patients with heart failure. Compared with enalapril alone, in a retrospective subgroup analysis, sacubitril valsartan reduced blood pressure in adults with both heart failure with preserved ejection fraction and resistant hypertension. In the context of research, sacubitril valsartan has been used at higher doses, 200 mg or 400 mg once daily, to treat hypertension. Small studies in adults with hypertension have confirmed the potential of this class of drugs to lower blood pressure. Other new drugs for which there is preliminary data are the new non-steroidal mineralocorticoid receptor antagonists, such as finerenone, for the treatment of hypertension. In addition, new aldosterone synthase inhibitors, baxdrostat and lorundrostat, significantly reduce blood pressure in patients with uncontrolled hypertension in Phase 2 studies. The dual endothelin A and B receptor antagonist aprocitentan also reduced office and 24-hour blood pressure compared with placebo over 4 weeks in patients with resistant hypertension in a Phase 3 study. Zilebesiran, an investigational RNA interference agent administered subcutaneously, inhibits hepatic angiotensinogen synthesis, and a single dose reduces 24-hour blood pressure for approximately 6 months. Drug combinations and titration strategies. Many patients will require more than one blood pressure-lowering drug to treat hypertension. Combining drugs from different classes may have additive or synergistic effects and result in greater blood pressure reduction than increasing the dose of a single drug. The superior blood pressure lowering efficacy of combination therapy is due, at least in part, to its potential to target multiple pathophysiological pathways that contribute to blood pressure abnormalities in each patient. If blood pressure remains uncontrolled with maximally tolerated triple combination therapy, a renin-angiotensin-aldosterone system blocker, a calcium channel blocker CCB, and a diuretic, the patient should be considered resistant and referred to an expert center for appropriate evaluation. At the same time, the addition of spironolactone should be considered. If spironolactone is not tolerated, eplerenone or another MRHA or a beta blocker, if not already indicated, should be considered. Higher doses of eplerenone, 50 to 200 milligrams, may be needed to effectively lower blood pressure. In a meta-analysis, eplerenone at a dose of 25 milligrams did not reduce blood pressure. Because of its shorter duration of action than spironolactone, twice-daily dosing of eplerenone may be necessary for the treatment of hypertension. Mineralocorticoid receptor aldosterone inhibitors, as a fourth-line therapy for blood pressure lowering, are an alternative to beta blockers in individuals who do not yet have a compelling indication for their use. When choosing a beta blocker, a vasodilator beta blocker, e.g., labetalol, carvedilol, or nebivolol, should be preferred. However, we note that the blood pressure lowering effect of beta blockade appears to be less pronounced than that of spironolactone in the setting of resistant hypertension. Only then should hydralazine, other potassium-sparing diuretics, amiloride and triamterene, centrally acting antihypertensive agents, or alpha blockers be considered. The blood pressure threshold for initiating antihypertensive therapy is not necessarily the same as the recommended blood pressure target after therapy has been initiated. In other words, the treatment threshold and the treatment goal may not be the same for a particular patient. In addition, it is imperative to exclude pseudo-resistance. Causes of pseudo-resistance, white coat phenomenon, poor adherence and persistence of treatment, incorrect method of measuring blood pressure, severe calcification of the brachial artery, Osler phenomenon, clinical inertia, inappropriate doses, inappropriate combinations of antihypertensive drugs, Munchausen syndrome, rare, behavioral factors, overweight, obesity, lack of physical activity, excessive daily sodium intake, excessive regular alcohol consumption. Side effects. Blood pressure drugs have many side effects, which are more common in women. Although the drug is generally well tolerated, common side effects include headache, cough, dizziness or lightheadedness, diarrhea or constipation, fatigue, ankle swelling, and erectile dysfunction depending on the drug class. Specifically, for patients with hypertension who are recommended to begin antihypertensive treatment with a baseline blood pressure greater than 140/90 mmHg, the recommended antihypertensive treatment target is 120 to 130/70 to 80 mmHg. There is strong evidence that the treatment goal is to lower systolic blood pressure to 120/130 mmHg. The evidence for the effectiveness of treatment to lower diastolic blood pressure is less strong in those treated with a systolic pressure target of 120/130 mmHg. Although most adults who achieve a systolic blood pressure target of 120/130 mmHg also achieve a diastolic pressure of 70/80 mmHg, not all will do so. In addition, adults who achieve systolic blood pressure control generally have a low relative risk of cardiovascular disease, even if diastolic blood pressure is between 70 and 90 mmHg. However, in part because of the known high risk of isolated diastolic hypertension in young people, the task force agreed that a target of 70 to 80 mmHg is appropriate. Catheter-based renal denervation has advantages but is not fully understood. Secondary hypertension in the young, age group 18 to 40 years. Secondary hypertension is more common in young people than late-onset hypertension, with prevalence in young people with hypertension reported by some specialist centers to be 15–30%. The main causes of secondary hypertension are drug-induced hypertension, e.g., estrogen-progesterone oral contraceptives, cold medications, and primary aldosteronism. Use of recreational drugs, CHOS substances, as well as dietary supplements and energy drinks, should be investigated. Isolated diastolic hypertension is defined as a systolic blood pressure of less than 140 mmHg with a diastolic blood pressure of greater than 90 mmHg. The isolated diastolic hypertension phenotype is more common in young adults, and especially in young adults with obesity or other metabolic disorders. In older adults with this phenotype, it is important to consider whether diastolic blood pressure was accurately measured. Hypertension during pregnancy includes chronic hypertension, precedes pregnancy, develops before 20 weeks of pregnancy, persists for more than 6 weeks postpartum, and may be associated with proteinuria. Gestational hypertension develops after 20 weeks of pregnancy and usually resolves within 6 weeks postpartum. Antenatal unclassified hypertension. Blood pressure is first recorded after 20 weeks of pregnancy and hypertension is diagnosed, but it is unclear whether it is chronic or not. Reevaluation is necessary at 6 weeks postpartum. The only treatment for preeclampsia is delivery, which is recommended at 37 weeks of pregnancy or earlier in high-risk cases. It is worth noting that proteinuria is not a mandatory feature of preeclampsia, but is present in about 70% of cases. In addition, because proteinuria may be a late manifestation of preeclampsia, de novo hypertension should be suspected if accompanied by headache, visual disturbances, abdominal pain, or abnormal laboratory test results, especially low platelet count and/or liver function abnormalities. The occurrence of hypertension in the first trimester, at the peak of human chorionic gonadotropin secretion, should prompt consideration of primary aldosteronism. In women with pre-existing and gestational hypertension, with or without preeclampsia, blood pressure should be reduced to below 140 mm systolic and 80 to 90 mm diastolic. There is no evidence to support lower blood pressure targets of 120 to 130 mm by 70 to 80 mm during pregnancy. Renin-angiotensin system inhibitors are not recommended during pregnancy due to adverse effects on the fetus and neonate. The drugs of choice for lowering blood pressure are beta blockers. Most data are available for labetalol, a non-selective beta blocker that also acts as an alpha blocker at higher doses. Metoprolol and bisoprolol are also considered safe. Dihydropyridine calcium channel blockers. Most data are available for nifedipine, which is generally considered the drug of first choice. Felodipine, nitrendipine, amlodipine, and isradipine may also be used, and methyldopa. A meta-analysis suggests that beta blockers and calcium channel blockers are more effective than methyldopa in preventing severe hypertension. However, it is worth noting that atenolol should be avoided as it may cause fetal growth restriction. Methyldopa is associated with an increased risk of postpartum depression, so caution is advised both during labor and in the postpartum period. Hydralazine may be particularly effective in severe hypertension in pregnancy and may be given intravenously to hypertensive patients. Although safety data on thiazide diuretics are limited and they should be used with caution during pregnancy. Other diuretics such as furosemide are not contraindicated and may be necessary in some situations. Treatment of severe hypertension during pregnancy more than 160 to 110 millimeters. Acute onset of severe hypertension, lasting more than 15 minutes, is considered a hypertensive emergency during pregnancy. Hypertensive crisis. Hypertensive crisis is defined as a blood pressure of 180 over 110 mmHg. Elevated blood pressure is common in acute intracerebral hemorrhage and is associated with an increased risk of hematoma expansion and death, and a worse prognosis for neurologic recovery. In trials testing immediate 6 hours blood pressure reduction to a target systolic value of 140 mmHg. The systolic blood pressure achieved in the intervention group was typically between 140 and 160 mmHg and was reported to reduce the risk of hematoma expansion. Excessive sharp drops in systolic blood pressure, 70, may be associated with acute kidney injury and early neurologic deterioration and should be avoided. If blood pressure is extremely high, an initial modest relative reduction of 10% to 15% over several hours may be considered. In patients undergoing intravenous thrombolysis, blood pressure should be reduced to less than 185 over 110 before initiating thrombolysis and then maintained at less than 180/105 for the next 24 hours. In patients undergoing mechanical thrombectomy with or without intravenous thrombolysis, there are limited data from clinical trials, but blood pressure should also be reduced to 180/105 before thrombectomy and maintained for the next 24 hours. Thus, patients with acute ischemic stroke and a blood pressure less than 180/105 during the first 72 hours after stroke do not appear to benefit from starting or restarting blood pressure lowering medications. For stable patients who remain hypertensive, greater than 140/90, for more than 3 days after acute ischemic stroke, starting or restarting blood pressure lowering medications is recommended. Overview of antihypertensive drugs. What you need to know. Angiotensin-converting enzyme inhibitors and angiotensin II receptor antagonists are the most commonly used classes of drugs. Concomitant use is not recommended. The risk of side effects is increased. They reduce albuminuria, reducing the development of severe end-stage renal failure. Angiotensin-converting enzyme inhibitors are not recommended for people of African descent due to the high risk of angioedema. Calcium channel blockers, dihydropyrins, nifedipine, sublingual, fast-acting, possible reflex tachycardia, amlodipine, side effect, lower limb edema, and non-dihydropyrins, verapamil, has a pronounced effect on heart rhythm as an antiarrhythmic and on blood vessels, as a dilator and anti-ischemic, but is not recommended for severe impairment of systolic contractile function of the heart due to the negative chronotropic effect. Diltiazem, similar action, moderate effects, recommended for use in case of impairment of systolic contractile function. Relatively fewer side effects, well tolerated. Thiazide, hydrochlorothiazide, and thiazide-like diuretics, chlorthalidone, indapamide. Thiazide diuretics can reduce potassium levels and worsen metabolic processes diabetes mellitus. Potassium can inhibit these processes, so its administration together with potassium-sparing drugs can slow down this process. The effect of thiazides is reduced in renal failure when the glomerular filtration rate of the kidneys is less than 45 milliliters, minute, and are completely ineffective at rates below 30 milliliters, minute, in which case they should be replaced by loop diuretics. Aldosterone antagonists, virospyron, eplerenone are used in additional high doses for resistant hypertension. Beta blockers, less commonly used among antihypertensive drugs, with vasodilator effect, which can be used additionally, labetalol, nebivolol, carvedilol, centrally acting alpha-adrenoblocker, doxazosin, as an additional agent for resistant hypertension and not as a first-line drug for starting antihypertensive therapy due to the high frequency of side effects. It can be considered in cases of prostate adenoma. Central imidazoline receptor inhibitor, moxonidine, physiotensin, if other antihypertensive drugs are ineffective. During pregnancy, the dose of labetalol should not exceed 800 milliwires in 24 hours. Monitoring of fetal heart rate is recommended. In case of pulmonary edema during pregnancy, intravenous nitroglycerin is administered. Sodium nitroprusside is contraindicated due to toxicity. During breastfeeding, antihypertensive drugs are excreted in breast milk in small amounts, with the exception of propranolol and nifedipine, which are excreted in breast milk in the same amounts as in maternal plasma. The use of beta blockers in bronchial asthma is not recommended. In chronic obstructive pulmonary disease, only beta-1 selective drugs are allowed. Diuretics should be avoided because they reduce bronchial secretion and can worsen the course of chronic obstructive pulmonary disease, so their widespread use for the treatment of hypotension is inappropriate. Sexual dysfunction, which should be taken into account in antihypertensive treatment. When using thiazide diuretics, beta blockers, and centrally acting drugs clonidine. In this case, it is better to use angiotensin-converting enzyme inhibitors, calcium channel blockers, and beta blockers with a vasodilating effect, nebivolol, carvedilol. I hope you enjoy my presentation. My goal is to make my presentations more interesting. This is the beginning. Thank you for your attention.